Hi, I'm Dr. Simon Fryler, consultant in clinical neurophysiology. Welcome back to the channel, and in this video I'm going to be talking to you about thoracic outlet syndrome. This is a very confusing condition, and I've been toying for quite a few years really and making a video explaining this and trying to work out the best way possible to try and explain it to as many people as possible. So please excuse me if I don't include everything with this, and I hope you enjoy what I've invested in making some artwork for this as well. I hope you enjoy that. I really appreciate everyone's support with the channel, with your likes, your shares, and your subscriptions particularly, and your comments. And this is my way really of giving back to you with your support by trying to give the best type of creative content that I can for you, and I hope it hits the mark. Let's start with the name. The name itself is very confusing. It's called the thoracic outlet syndrome. This is the rib cage. The top end is technically known as the superior thoracic aperture, and aperture is an opening, superior means on top, and thoracic is of the thorax, of the chest. And the superior thoracic aperture is also known as the thoracic inlet to anatomists. The lower opening by the diaphragm, or the inferior thoracic aperture, is actually called the thoracic outlet. And for some reason it's switched so that the thoracic outlet has moved up to the superior thoracic aperture, and is now known for this area over here, at least in clinical parlance. Now, whilst we're talking about the bones, we need to start talking about cervical ribs. So there are 7 cervical vertebrae in the neck, and the vertebrae are these bones which surround the spinal cord. They protect and support it. So 7 of those in the neck, there are 12 of those in the thorax, and the first rib is supposed to form at the point of the first thoracic vertebra. Now, in about 1% of the population, these can start occurring at the 7th cervical vertebra. That's the lowest of the neck bones, and so there can be an extra rib over there. This can be complete and make its way all the way from the vertebra to the front of the front to where the breastbone is, to where the sternum is, or it can be partial, in which case there are often fibrous bands which join it down onto the first thoracic vertebra. What can happen is that the brachial plexus, which we'll talk about momentarily, and the vascular structures can end up lying on top of this cervical rib or on top of these fibrous bands, and they can actually cause pressure and constriction on these soft tissue structures and actually lead to damage, and therefore they are a known predisposition. Now, whilst many people have got these cervical ribs, only a tiny proportion go on to having a true thoracic outlet syndrome, and we'll come back to this point a bit later on in the video. Now, in terms of the soft tissues, we've talked about the bones so far. This is a very, very busy area. We've got the big blood vessels which come out, so namely the subclavian arteries and subclavian veins, as well as quite a few nerves. Now, I'm going to focus on the important group of nerves known as the brachial plexus. The brachial plexus transfers the individual nerve roots exiting the spine and combines the various nerve fibre tissues into their eventual single nerve destinations. Apart from them, there are lots of muscle tissues in this region as well, because the shoulders are highly complex joints, and so it's no surprise that issues relating to any of these structures can cause discomfort in this region, together with a host of symptoms and distinct clinical syndromes. And because of their anatomical positioning, they tend to be called thoracic outlet syndromes, but they can be in reference to many and very different entities. There are 5 types which we're going to be talking about. The first type is traumatic thoracic outlet syndrome. The second type is the symptomatic thoracic outlet syndrome. It's also got a multitude of other names. It may be called non-specific thoracic outlet syndrome, disputed thoracic outlet syndrome, cervicoscapular pain syndrome, or as I prefer to call it, BRACHIALGIA. There's the vascular thoracic outlet syndromes, which may be either arterial or venous, and then there's the true neurogenic thoracic outlet syndromes, which we will come to at the end. Let's talk about trauma first. So this is usually mostly an acute cause in terms of an act of violence, impact, blast, penetration, traction, you name it. It tends to be unilateral, tends to occur just to one side because of the mechanism. Because it tends to be traumatic in nature, this predominantly affects men, who seem to get into trouble more often, and may either be primary or secondary, which means that primary is due to the actual direct force of the injury or traction, or secondary, for example, if a clavicle has snapped and penetrates inwards, that can cause a secondary injury to the tissues behind it. And it tends to involve the neural and vascular tissues, but it has an emphasis more on the neural tissues than the vascular ones. Again, it depends on the exact circumstances, but overall that's the broad picture. And management will be surgical for the most part, quite significant polytrauma really, and will effectively be a cross-disciplinary management involved, whether it's vascular, orthopedic, neurosurgical, etc. And of course, care for rehabilitation during and afterwards will of course be multidisciplinary, involving many different groups of teams, physiotherapists, occupational therapists, etc. The next group of thoracic outlet syndromes are the symptomatic type, because these are actually by far and away the most common, and if you're watching this video having been given the description of having thoracic outlet syndrome, chances are you probably have this type. So this is really an anatomical label that describes the region of the pain rather than the underlying cause, of which there can be quite a few. Now, I suspect that a very large proportion of people who are given this diagnosis actually may have rotator cuff issues. Again, the shoulder is hugely complex. The rotator cuff is basically formed by 4 main muscles which stabilize and keep the humerus in its socket when it's abducting. And usually it's the supraspinatus muscle at the top that sustains the most degenerative issues, and it's located just over here. Now, in terms of symptom signs, provocative things, symptoms of course are positive. That's why people present to their healthcare practitioner, and the majority of people with these symptomatic thoracic outlet syndromes will be complaining of pain or tingling in the upper arm going down the arm, and perhaps maybe heaviness and weakness of the arm too, but by far it's pain and tingling. In terms of clinical examination, signs will be negative, and there can be provocative tests. I'm not going to go into individual types of provocation tests to try and reproduce symptoms or to obliterate pulses, but provocative tests can be positive, but it has to be said at the same time that even in normal asymptomatic individuals, if you try these provocative tests out, you may actually be able to induce these type of symptoms, and so they're said to have relatively high false positive results, and therefore they can be a little bit dubious in terms of actual clinical diagnostic utility. And of course, those who may have concomitant carpal tunnel syndrome actually may have a higher proportion of these provocative tests being positive, and so that's another thing to be aware of when performing these procedures. In addition to which, people with these type of symptomatic thoracic outlet syndromes may also have a cervical rib. Remember, cervical rib is very common. Occurs in about at least 1% of the population, and so this actually may be a finding which may cause concern together with the symptoms. But the most important thing about this is that all laboratory investigations, whatever type of imaging, flow studies, electrodiagnostic tests, they will all be negative and will not show any damage to the neurovascular tissues. And so these symptomatic thoracic outlet syndromes, they are positive in terms of symptoms, negatives in terms of signs, laboratory investigations, and may have equivocal or possibly positive provocation tests. But ultimately, there's no actual evidence for those who eventually derive this diagnostic label as actually having neurovascular compromise. When no other cause is identified, then we can safely say that the patient has got symptomatic thoracic outlet syndrome, or brachialgia, or cervicospinal pain syndrome. Now, in terms of the mechanisms, this can be very technical, can relate to the scapular position, for example. If it's dropped, it can cause traction downwards and therefore cause some stretch on the nerves of the brachial plexus, or whether there are perhaps imbalances or fibrosis within the scalene muscles. In terms of treatment, the mainstay is actually conservative, whether it's rest, avoidance of aggravating movements or occupations, taping may be something for the short term, perhaps better bras if that's relevant in terms of the mechanism, certain exercises which needs to have expert physiotherapy guidance for, various injections, and of course pain relieving medications. Now, this is a very complex topic, as I've said already, and I think it's best primarily led by physiotherapy colleagues. In terms of the vascular causes, these are the most common types of real true thoracic outlet syndromes. In terms of the arterial type, it affects the subclavian artery, where it's being compressed. There can be post-stenotic dilatation, there can be ischemia, there's a lack of blood going to the tissues, thrombus, which means development of clot, and even embolization, where fragments of clot shower off down into the arm. The arm itself will go cold, it will go pale, it will go blue, with loss of pulses, and if there has been showering of emboli of these little clots, one will be able to see those even in the skin itself. Treatment is, of course, surgical. Venous thoracic outlet syndrome, so these are quite different really to the arterial and the neurogenic types. Here there's a thrombus, there's clot sitting in the venous system of the subclavian axillary veins. Tends to be men, tends to be unilateral, tends to be the dominant arm, relates really to vigorous exercises, space-occupying compressive lesions from the outside, causing a constriction and impeding the flow and allowing thrombus to form, or even thrombotic predispositions and tendencies. It's very rarely relating to the cervical ribs, in contrast to the arterial and the neurogenic types. If it occurs acutely, there may be swelling, palpable clotted axillary veins, pain and cyanosis in the arm. In more chronic presentations, there may be venous collateral formation and dilated veins in the neck, chest and shoulder region. In terms of the treatment, it's led by the vascular surgeons. Thrombolysis, clot busting drugs followed by anticoagulation is the mainstay of treatment. Other things may be required depending on the circumstances. True neurogenic thoracic outlet syndrome. Finally, so here this is really the crux of the talk. This is a very rare condition. It occurs in about 1 to 3 per million people per year. In terms of my own clinical practice, these are actually the type of incidences that I see from my catchment area of work. I think that a lot of people with the label neurogenic thoracic outlet syndrome have been sort of lumped together from the symptomatic group together with the true neurogenic ones, sort of swelling the numbers above the vascular types. It's not the case at all. The actual true neurogenic types are incredibly rare. It's associated with the partial cervical ribs with the fibrous bands, in contrast to the arterial ones, which actually tend to be more associated with the complete cervical rib, which is interesting. In terms of predispositions, it tends to be women. And in my own particular clinical practice, I have yet to see a man with it. The average age is said to be around about the age of 40. For my own clinical practice, I tend to see it as a bit of a bimodal distribution, usually those sort of 20 to 30 group, and there's a kind of like sort of 50-ish group as well. As you can see from those kind of numbers, this is a very chronic type of condition. It takes a long time to get diagnosed, and that has actually important bearings in terms of the neurophysiology as well. Now, we're going to focus on the classical neurogenic thoracic outlet syndrome, and this is a lower trunk brachial plexopathy, which means that the lowest fibres of the brachial plexus are those which are being damaged. So that means, in practical terms, the T1 fibres are going to be more affected than the C8 fibres. And so this will lead to numbness in the forearm and then the little finger, and then weakness and wasting at the base of the thumb. And the way I like to describe it is basically it's the carpal tunnel syndrome that doesn't make sense, because basically the wrong fingers are going numb for the fingers which are going weak. So in carpal tunnel syndrome, one's going to be having these 3 fingers really, which are the ones which are going numb, together with weakness of the base of the thumb, so that's the median nerve. However, in thoracic outlet syndrome, it's this part of the arm that's going numb, and this part of the hand which is going weak. So there's this sort of splitting of the hand really, in terms of the weaknesses on one side and the numbnesses on the other side. And so it's the carpal tunnel that doesn't make sense, particularly for those who are on the younger side of those who are developing it, on the sort of the wrong age group. So that's another clinical pointer as well, if one is in a point of confusion. Of course, for those who are older, there's a broader differential diagnoses, whether it's going to be severe carpal tunnel, radiculopathies, alternative causes for brachial plexopathies. So the ones that I tend to be referred to are, on the whole, are actually accidental. They come in via the GP as a query carpal tunnel because they've got severe wasting, but actually we can see pretty quickly when we speak to the patients, examine them and then do our nerve tests, that actually we're not dealing with carpal tunnel. So for people who are involved in this, it's actually difficult to have it as a confusing factor. But if you don't see this, on a even semi-regular basis, then actually it can actually seem to be like a carpal tunnel. But to those of us who are in the know, as it were, and sort of constantly think about this, it's actually quite distinct. But basically, it's the carpal tunnel that doesn't make sense. In terms of the electrodiagnostics, I just will mention a little bit for those of you who are neurophysiologists. One is first of all looking for reduction or absence of the medial antebrachial cutaneous nerve of the forearm response, because that comes off from the T1 dorsal root ganglion in its origin, and that will be followed by the fifth finger over here, which comes off from C8. In terms of the motor studies, one will first see reduction in the APB, which is mainly T1, followed by FDIO and then ADM. F waves, there might be some slight prolongation, but not very much usually. And then in terms of proximal conduction block studies, there was a huge controversy back in the early 80s about one set of papers about this. So the standard techniques are nothing to rely on in terms of proximal stimulation. There is something to be said for triple stimulation techniques, but really, because this is such a chronic condition, by the time anyone gets to see us, or by the time we get to see them really, there's already established axonal loss, and therefore the standard tests can show this very beautifully without need for very technically demanding and challenging tests. So the AANEM monograph on this by the Ferrantes is a really excellent resource. I commend anyone who's interested in thoracic outlet in general to read it, or particularly those from the neurophysiology community to have a look at it. It really goes into detail with this, and I fully concur with their entire monograph. Not that they need my approbation. It's also worthwhile saying that there are non-classical forms of thoracic outlet in terms of the neurogenic type, and it's just for something that we need to be cognizant of, because there can be pre- and post-fixed brachial plexuses, and that's something that those who know about what that means know what I'm talking about. One can also have formation of the trunks through the scalenus muscles rather than between them as well. And that can also add extra complexity and mechanisms as well, rather than cervical ribs. And there can also be additional scalenus muscles too, which also cause constriction within that triangle over there. Anyone who's been following this channel for a while will know that I'm a big fan of evidence-based medicine. It's quite a confusing area really, because of all these different terminologies and how people lump and split different conditions together under the same name. The Cochrane Review of 2014 really deals with it very beautifully. But I would say as well that there's been quite an evolution really in terms of practice and thinking over the last 10 years certainly, from perhaps more of a conservative first approach to more of an active interventional approach. And so it's really important to seek an experienced surgeon in the first instance. That would be my personal recommendation, because by the time that someone's had this diagnosed, there's already been considerable axonal loss, and so it's important to try and reduce this from progressing at all. And so there are very good outcomes in centres which are used to dealing with these types of procedures, with the risk of complications such as pneumothorax being relatively small, in a couple of percentage of patients really. Hospital stays roughly 1 to 2 days depending on centre, and the chances of recurrences are very small. In terms of expected improvements, these may not be necessarily wonderful, depends on how far things have progressed in the first place, but certainly will prevent them from getting any worse. Of course, there are lots of nuances in terms of what are the best approaches and different types, which are well beyond the scope of this video, and I was pointing you towards the surgeon involved for further information about this. So thank you very much for watching the video. Hope you enjoyed it, hope you enjoyed the artwork. Please do support the channel by liking, sharing and subscribing. Your comments are always welcome. I would also respectfully ask, if you have got symptoms, to be seeking advice from a professional rather than just Googling me really and putting them in the box below, because I can't really answer those for you. And wishing you all the very best, and see you in the next video. Bye.